Hi everyone, my name's Sharon Martin. I'm from the charity Fertility Network UK, and tonight we're hosting a webinar to talk about egg quality and quantity. This has been one of the most talked about webinars that our charity's actually brought to you. We have got hundreds of people signed up for this one tonight, so it's obviously a subject that people want to know lots more about. So I'm really delighted to bring to you Dr. Jeve, who is a consultant subspecialist in reproductive medicine. He's the clinical director from Birmingham Women's Children NHS Foundation. And Dr. Jeve will go through a slide presentation with you, hopefully providing you lots more information on the subject of egg quality and quantity. At any point during the presentation, you'll see at the bottom of the webinar, there's a chat box. So if you've got a question that you want to ask, if you just put it in the chat box, after Dr. Jeve is finished, I will then ask those questions on your behalf to Dr. Jeve. So feel free at any point during the webinar to pop your question in there, and I'll just take a running note of them. And once Dr. Jeve is finished, then I'll put your questions to them. I hope everyone finds they get something useful out the webinar tonight, and I'll just hand over to Dr. Jeve now. Thank you.
Hello, good evening everyone. And I will start sharing the screen. Hello, so today we are going to talk on the egg quality and the IVF. As Sharon kindly mentioned, any questions, please feel free to let us know, and then we'll discuss at the end. So we'll start the presentation with the outline. Okay, so egg quality and IVF. So the outline of the presentation is we will discuss what is the quality and quantity first, and then we will start discussing on the natural decline in the fertility. And then the third thing, we will discuss how to improve the egg quality and quantity. Obviously, we can increase up to a limit, and therefore it's very important to understand the pathophysiology. And then the next step would be the medication, meditation, diet, and lifestyle, and the supplements. So this is our outline, and then the final thing would be the conclusion. As famously Albert Einstein has said, the formulation of the problem is the most essential than the solution, which may be merely a matter of mathematical or experimental skills. And that absolutely stands true when it comes to the fertility treatment, IVF, or subfertility. The most of the time should be invested in finding a cause and correcting a cause, and then it just becomes the protocol, some drugs, and getting the success out. We all know that quantity declines with the age, and this is the classic graph.
Jeve, sorry to interrupt, but your slides are not on the webinar.
Oh, I will share the whole screen and let's see if that works.
Yeah. Right.
Okay.
We can see it now.
Oh, thank you very much, Sharon. Thank you. Thank you, everyone, for your patience. So the quantity, we all know that quantity declines with the age, but as we could see on this graph that at any given age, it's not absolute that the quantity is same. As you could see, in 43-year-old could have the different level of egg reserve as shown in this graph. So when we start from the fetal life, the female fetus has 6 to 7 million of oocytes or eggs at 20 weeks of gestation. At birth, they become 1 to 2 million. At puberty, it's 300 to 500,000. 37 years of age, it's 25,000. And at 50 plus age, it becomes around 1,000. So as you could see, there is a massive decline in the egg reserve at each stage of the life, from the cells beginning in the fetal life to adult life to the reproductive life. And some of this egg decline is without even the eggs getting activated. But during the reproductive life, how we measure the quantity? AMH has been widely used and is better and precise marker available in the egg reserve as compared to the other hormones. And it comes from the pre-enteral and enteral follicle, which I will discuss in a minute, and therefore it's better reserve. Antral follicle count, on the contrary, just checks for the follicles which we could see on the scan, and therefore it has some limitations. However, it is again a very good reserve marker for a given cycle. Follicle stimulating hormone, it's fine. It will just tell us qualitatively whether there is a menopause or there is not a menopause or the range, but it won't give more accurate quantity in terms of the egg reserve. So that's how we calculate and we see the quantity. So there are different types of eggs at any given point in the ovary, and those eggs are either primordial follicle, that's the immature eggs, which we can call also the sleeping eggs, and they remain dormant for up to 50 years. They do not respond to hormones, and at some point they get awakened. So when they get awakened, the primary follicles become primordial follicle become primary follicle, and they start on their journey towards either ovulation or the destruction. They are not responsive to the hormones, and they are not seen on the ultrasound scan. So basically, this primordial or primary type of follicles, type of eggs, which we can't measure and we don't know. The secondary eggs, the secondary oocytes are after 290 days of these follicles, they will become to the secondary follicle. And at this stage, the follicle starts to produce the AMH. They are too small to be seen on the ultrasound scan, and they respond to the hormone. Then the antral follicles. This stage lasts up to 50 days. They are visible on ultrasound scan because they are size of 2 to 10 millimeter. They produce the AMH and estrogen. So in nutshell, there are different types of eggs at the given condition. And as we all can see, only we could see that what I have mentioned in number 3 and number 4, either with AMH or with a scan. So some form of eggs which we can't see, and we don't know how they get awakened or why they just stay sleeping or dormant for quite a long time. So this is the big gap in the research currently. Now, this is about quantity. When we come down to quality of the eggs, it's again very, very difficult to define the quality as a very as very subjectively. So it's subjective, it's not very objective. And as you could see in this slide, as on the top right hand corner, we could see that there's normal eggs, which looks absolutely very nice cytoplasm, and one tiny little bit what you could see as a round body, we call polar body, and that indicates the maturation division. But if you could see in all other eggs, they have different things in that, and then that denotes poor quality eggs. And when we say poor quality eggs, in general terms, we either see some of these features in those eggs. The relationship between eggs and the egg quality, age and egg quality is shown in this graph. As age goes up, the miscarriage rate or the genetically abnormal embryo rate goes up, and therefore the average percentage of embryo they are genetically normal could go down, as shown in this slide. So that's again one of the indicator of the quality of the eggs. There are two areas of the eggs, and the synchrony between these two areas are very important. And those areas are a nucleus, that's where the DNA material is, and other is egg cytoplasm, where there are mitochondria and other energy cells, and then they support. When the egg is developed, the synchrony between two and the maturation of both is very important. If there is a dyssynchrony or there is a problem in the number of chromosomes, that can again result in not a very good quality eggs. And the reason, as I said, this knowledge is important because that decides the outcome of the fertility treatment. Quantity and quality of eggs affects the success of the IVF or the fertility treatment. And as this graph shows, the natural conception rate goes down with age, as we all know, and the miscarriage rate again start getting up. And this is because of the reduction in the quantity as well as the quality. Reduction in quantity gives us the less statistical chances, and reduction in the quality gives us more genetically abnormal eggs or embryos, and that increases either failed implantation rate or miscarriage rates. So then the question is why this happens. apart from age-related phenomena, is there anything else that can, and again, there are certain many medical conditions which we are not discussing today, cancer treatments, etc. But what we are discussing here is the oxidative damage, or the damage can happen in the eggs due to different reasons. So oxidative damage, diet, disease, pollution, stress, allergies, they can contribute with the free oxygen radical damage. And I will explain you what that means and how this affect. Smoking and alcohol, as we all know, again, has a negative impact. Damage is mainly by what we call ROS or RNS. So basically, they are the chemicals, they are the species which are produced with oxidation, and then they affect different part of the cells and damages the cells. So oxidative stress, in body, there is a free oxygen radical clearing activity and antioxidant activity to clear those bad chemicals. But when this balance becomes imbalanced, then the stress becomes higher. That affects all the cells, including the egg cells or sperm cells. It could be in the endometriosis and any other the gynecological condition which I have mentioned here on the slide, including PCOS, and even in unexplained, because we don't know, but that could be happening in the body at the microscopic level to damage the eggs or the sperms in men. So basically, this is how the free oxygen or stress-related damage can cause the effect or adverse impact on the eggs or sperms. So this ROS affects on the lipids, which are the fat molecules, and breaks their chain. And all the cell membranes contains the fat molecules, and that can change its fluidity and permeability and damages the cells. It can also affect the proteins and the DNA. And this is why, then this is how it reflects in the quality of the eggs. Or if there is more destruction, then it's also impact the quantity of the eggs. So what can we do to improve the egg quality and quantity? So two approaches. One is we can either work on to improve the quality, or second, we can work on to aim for high quantity. So either improve quality or try to have the more quantity, because then statistically it will be advantageous to get a good quality eggs out of many. And this is the approach B is mainly thought through the IVF centers, and this is where then we start getting, okay, let's do the IVF, let's try to get more eggs out in one cycle, so that statistically we'll get the more chances of having success. Or it would be logical to think that we could do both. But how we could do that? So then, as I said, and I have spent significant amount of time in finding the problem and discussing the problem, then logical would be to aim to reduce the oxidative stress. Second approach is obviously we need enough raw material for the activation of the eggs and the development of the eggs and that all that process. If the raw material is not enough, that's not going to help us to give the good product out. And third thing, which is more medical, is having the personalized stimulation protocols and IVF treatment cycles. And I will come to that again, how that can impact the quality and quantity. But what is important is having the personalized treatment, because one size obviously doesn't fit all. So we need to have that approach. We come up with what we call P4 fertility approach, which includes predictive care, preventive care, personalized, and participatory. What does it mean? Predictive is predicting the response, predicting that, okay, if we start treatment at this stage, what will happen? Or what are the prediction of complication happening? So prediction for success, prediction for adverse event, and then clearly comes back as prevention. Obviously, if we know that something may not work or have increased risk, we need to have the preventive approach. And that links into personalized care. And personalized care is treating every woman as an individual, and looking into all the data and all the predictors, including AMH, FSH, age, lifestyle, diet, and then personalizing a plan for that woman is personalized care. And participatory is very important, that the couple is in charge or in control of the treatment. That's what the P4 is. And all these things clearly helps to reduce the stress associated with the symptoms, and that reduces the oxidative stress. And that's why this is important. So first we start with diet, dietary antioxidants and lifestyle. Now, there are so many good foodstuffs that have the antioxidant that clears those ROS or RNS, those the damaging chemicals in the body, and clears that up so that the egg quality and quantity, and it naturally helps to build good quality gametes and the cells in general. So I have given the examples of the diet which has plenty of dietary antioxidants. Regular or moderate exercise helps. Obviously, smoking is not good. Reduction in alcohol intake is important. Avoiding overeating and constant eating, as this can cause constant inflammatory response in the body. And not just it is related through the weight, but weight, fat, and plus this constant eating have the pro-inflammatory reaction in the body, and that can increase the number of oxygen radicals or the bad chemicals that can damage the eggs, and that's why that's important. And the lifestyle changes to reduce the physical and mental stress. Again, it's very easy for me to say this, but it's difficult in practice because of the different work style patterns, the work-related issues, and the other issues. And there is not a single magic answer that if we do A or B or C will help us. It's the combination of diet, lifestyle, doing everything that reduces the stress. And again, not one size fits all. Somebody might find it helpful to have acupuncture, while other person might find it helpful to have moderate exercise, or somebody just feel relaxed by watching movie. So these are the different things that and this is why the personalized approach is important. And this is why we never have a trial proving that, okay, acupuncture helps or ABC helps or doesn't help, because that is not meant to be for everybody. So that really leads to the titled it as meditation. You obviously don't need to do actual meditation. If you could, that's fine. But basically what meditation covers is a stress management. As I said, that what we think and how the stress is, physical or mental stress, can damage the oxidative damage in the body. So therefore, we need to have the support. And it is mandatory in the UK to have the counseling support for all couples going through the IVF cycle, and all IVF centers have a counselor. Personalized care, as I mentioned you earlier, that having this personalized care throughout helps to reduce the stress of the patient, and that leads to the constant support during a treatment. So having one port of contact and having somebody who is able to answer their questions and queries 24/7 gives patients a lot of reassurance during the treatment cycle, and that helps to reduce the stress and obviously works towards the common goal of a doctor, patient, and everybody to have a success. Group support, and again, FNUK is doing a great job giving the support in the UK for all the patients. But as I said earlier, that again, in this approach, these are some examples. They all could be used together, or if somebody finds one option is better than other, again, that could be used. Exercise, we mentioned already. So as physical exercise is important, so as the mental exercise is important. So we come down to medications now. Mechanism, there are loads of mechanism for all these supplements or the antioxidants, and there are proposed mechanism how they help. Commonly used vitamin D, vitamin C, minoxidil for the PCOS type of patients and not for all. L-arginine, polyunsaturated fatty acid, CoQ10, which is again very commonly used, DHEA supplements for mainly used for the reduced ovarian reserve. But basically, all these supplements or the antioxidants helps on and targets the different molecule, and then they help and they work on the different mechanisms, and all these are the proposed mechanisms. One thing which is very important, this is why I put this slide to explain you that the right time to have the medications is long before actual ovulation. And this gives you typically 60 to 70, 90 to 70 days before. As you could see in the graph, that it starts from the 90 days to 20 days before actual egg collection or ovulation is expected. And this is the time where the egg quality is formed. Therefore, we advise normally the supplements or the antioxidant or any diet or lifestyle changes 3 months before actually we are expecting egg to come out. And this is the physiology behind that. So if we want to really see the maximum effect of diet, lifestyle, supplement, meditation, medication, etc., we need to give 3 months at least before we the date of egg collection or before we are expecting ovulation. So that's the time frame we need. When I looked into the evidence, okay, it's great to have the supplements, medication, etc. And but what is the current evidence? What the trial says? And I looked into the Cochrane, which is the best available evidence in the world, the best process of acquiring, analyzing, and appraising and publishing evidence in the world, in the Cochrane reviews, and they are mainly for the good quality trials. So let's see what the latest, and this was published just this year, a couple of months ago. So they have included 63 trials, over 7,000 women in their study. And they found, when they analyzed the results of these different trials, out of hundreds of fertile women who do not take any additional antioxidants, 20 would have a baby, as compared to 24 to 36 out of 100 who, if they take the antioxidants. They have also analyzed whether there is any harm of these antioxidants, and they haven't seen increased rate of miscarriage or twins or any detrimental effect on the pregnancies or ectopic pregnancies. However, these trials have some limitations in terms of design, having robustness, and therefore they concluded it's a low quality evidence. It's not a very high quality evidence. The problem in the IVF is, because there are so many variables, we always struggle to get one variable to show the significant effect, because then there could be laboratory factor, there could be other factors. And therefore, it's always difficult to prove or disprove use of, say, DHEA, coenzyme Q10, or any other supplements to a significant level in IVF. And that's the bit of limitation. But as I said, this is the best available evidence so far on this. So I will just discuss a little bit more on CoQ10 and DHEA, because that's commonly used and most of the patients ask me the questions on this. And these are the different scientific names for this, and this is the proposed mechanism, how it works. In human fertility, the efficacy is still in evaluation. As I said, that we are not absolutely sure that how much it helps or works. Obviously, as I said earlier, there is a poor, low quality evidence, but it supports the use. And there is no harm noticed with this in terms of the long-term harm. Its antioxidant is inhibit lipid peroxidation and DNA oxidation. And as I mentioned earlier, ROS, RNS actually act on 3 different ways. And one way to act is on the lipids. So it tries to stop that. And it helps mitochondria, which is the energy or powerhouse of our cells. And that's the proposed mechanism of it. I mean, and again, this is present in the diet and naturally present in the diet. We're talking on the use of additional supplementation. Second one, widely researched, is DHEA. And I did one meta-analysis 2 to 3 years ago on DHEA. There were 2 trials published by that time, but we did not see any significant evidence to improve the ovarian response. So basically, DHEA is a raw material that is required for ovaries to produce the hormones. It comes from the gland which is present over the kidney. The argument is, if there is aging, and the aging process of the adrenal can cause the reduction in DHEA, can cause the poor response. And therefore, the supplementation came in picture. So how does it work? These are the different mechanism as proposed mechanism, but as I said, it basically helps to give the raw material to increase the androgen, and it helps the ovarian response, and this is the proposed mechanism. Currently, it's still widely studied, and there are a few trials underway, but the evidence is mixed. Again, it's recommended 3 months pre-treatment use, but if somebody had a normal level of DHEA, we don't know whether it will help, but clearly if the DHEA levels are less, it helps. Now, again, many clinic, we do not monitor DHA continuously. We just discuss this, and then that becomes optional. Use the supplementation before the ovarian response. And as I mentioned earlier, it's the combination of every factor helps us to get the best response. Medications are very important, and there is a lot of debate on which protocol is good, short or long. And again, there is no right or wrong answer. My study or all the studies has not shown any difference between the short or long in terms of the success rate in poor ovarian response group. Timing is always important, when to stimulate rather than how to stimulate. If we have a good number of follicles coming and cohort coming in the cycle, clearly we are expected to get the best response. Drugs, again, there are two types of drug, recombinant or natural. There is no significant difference in the trial. And again, all this personalized treatment comes in for the protocol and drug based on the experience, based on the previous response, or based on the quality of the eggs and embryos in previous cycle. And this is how we all fertility specialists manage the protocol as well as the drugs. Dose-wise, higher dose is not always good, and so does the low dose. We have to get the very right balance of good quality eggs with a good quantity. We want good quantity to have the statistical results, but if we just keep increasing dose, we do not gain the significant gain in terms of the number of eggs, but we might damage the lining, and we also might damage the quality of the eggs. And that's why it's important. And that's why there is always a ceiling dose in every unit, and they don't go beyond that dose. Adjuvants. People have tried various adjuvants. We haven't seen increased success rate with that. Laboratory factors are important. And P4 care, and this is why I explain you, the prediction is important, as the personalized protocols are important, that how we decide what dose, when to give, and how and how to do the cycle, IVF or ICSI. Again, as I said, there is no difference, but normally we do not recommend ICSI if there is not male factor problem. The IVF is then better in those situations. So conclusion, pre-treatment optimization should be considered, including diet, lifestyle, and the various supplements. One size doesn't fit all. Therefore, personalized treatment is important. General health, we have already discussed a lot, and that's very important, including stress management. The choices on the supplements or which form of antioxidants we want to use should be discussed and with the professionals and patients, and then the choice should be made. Folic acid is recommended, and please do not consider folic acid as a part of this presentation because it works on the different mechanism, and it's absolutely recommended for any preconception, anybody who's trying for a baby, to avoid the fetal anomalies, and it's not for the success of the conception. Thank you.
Can I just say thank you to Dr. Jeve? That was really interesting, and I've got a number of questions that patients have asked, so I'll just take them in order. Some people have asked about male fertility, and does the exact same thing apply for improving quality of sperm? That might be a conversation in another webinar for a urologist to come along, but I'll ask you that question, Dr. Jeve. Does the supplements you're talking about work the same, and should the male be part of that, taking of the supplements during fertility?
Yes, I'm sorry, the video, I think I will try to help the video, but if it works, it's fine. And I know that you all are hearing me, so that's fine. So male supplements, yes, that's again, is as you rightly said, the male fertility or male DNA damage in the sperms is a separate topic. But what is good for one cell is also good for the other cells. And the many principles are quite same in the antioxidants. Uh, and some of the molecules might be little different in zinc, etc. in men, but most of this diet, lifestyle, stress reduction, reduction in the oxidative damage is important for men too. Obviously, what is not important is the protocol, etc., because we don't use any drugs to induce the sperms in the normal circumstances. I'm not talking about rare conditions. But to improve naturally the quality of sperms, many of these principles we could easily import. And that's the same, because things are, and this is good for even for the cardiac cells, reducing the risk of stroke, etc., etc. So this has the general benefits of diet, lifestyle, moderate exercise, reducing stress, and antioxidants.
Okay, thank you. That's a more personalised question, Dr. Jeve. There's a patient here asking that they were told by the embryologist that one of their eggs is showing some resistance and that it was not great quality. What else can imply bad egg quality that can be seen by the embryologist?
Okay, this is a very good question, and I do come across certain comments that sometimes the embryologist make a comment that egg was resistant to ICSI, or sometimes they make a comment it was as soft as like a cheese, and easily, and that both implies that basically what embryologist is trying to say here is they were not normal, what they were anticipating or expecting. So now there are different questions why this happens, and as I said, the process starts long back of development of eggs, and the active process is around 2 to 3 months time. Now, some of these are related to the way the ovaries are, or the way the biological factors are, and many things are unexplained in those situations. But some of these things we have seen with the associated protocols, drugs, and the duration of the protocol, and using certain molecule or not. And all embryologists will anecdotally will agree that, oh, we switched on from this drug to that drug, etc. So this is very difficult to answer, that why particular occasion that we had an increased resistance in the egg cell wall, and whether that's the tendency, and that could be related to some genetic factors of making a very strong cell wall. And we don't know that, and obviously we need more information in this personalized case scenario or to explain. But answering generically, any comment that embryologists make implies that they did not find this egg was the normal what resistance they were anticipating. So how we cure this is difficult, but as I said, these general measures will help generally. And again, statistically, if we have more quantity, sometimes it might be the finding in 1 or 2 eggs which are not normal, but then other eggs could be normal.
Okay. I've got another patient asking a question that I'm asked a lot working for the charity. So we've got a patient who had a recent failed cycle. They had 7 eggs collected, but this question I think I'm probably asked at least once a week. I get 12 eggs, and they're then told only 3 were of suitable size to then go forward for ICSI or for IVF. Why is it when you go for a cycle of IVF, are they not all the correct size? And is there anything that could be done to actually ensure more of the eggs are of the correct maturity to ensure you've got the best quantity suitable for ICSI or IVF?
Yeah, so now I will go with 2 lines here. The first is, and I will work reverse way backward. And so I will start with ICSI or IVF. The difference between ICSI and IVF is, when we do the ICSI, we need the egg at that time. So normally if the embryologist is doing ICSI in the afternoon, 1 p.m., sitting with a dish, that means the embryologist need the egg to be mature and of certain stage of maturity to put a sperm inside it. Versus if we are doing IVF, so we could leave all eggs and sperms together, and then the egg will mature during the course of a day or night, and accept the sperm in, or the sperms can then successfully penetrate the eggs and the fertilization can happen. And therefore, this is why we never see that higher success rate with ICSI. Always there is a perception that ICSI gives the better So, or ICSI is then the next step to the IVF, which is not. And therefore, the careful case selection is very important. So if we choose ICSI in all patients, we might not find all the eggs suitable for having the sperms injected. But if we do IVF in those patients, that means we are giving opportunity to all eggs to accept the sperms, provided the sperms factors are good. So assuming that the sperms factors are not good and we absolutely need to do the ICSI, that means we need to get the maximum mature eggs at the time of injection of the eggs, sperm inside the egg. So then how we could do that? So that's why then the reverse way it comes in, then the collecting eggs at right time, having the trigger at right time, and then if we work backwards, then the protocol. So if there is like dyssynchrony between the egg development, then changing from one type of protocol, antagonist to agonist, or short to long, it depends. And this is how we need to then balance that when we could get the good cohort of maximum eggs. As I explained you in my diagram and before, that the different eggs start their journey at different time. When we start stimulating, we get the cohort of eggs which are ready, but that's say 5, 6, whatever number, but they are not all are at same stage. So they, and as their starting point is not same, their maturity could be different. But this is what then the IVF clinics do and need to do, is to find the good cohort at the given time. And that comes in the personalizing the protocols, looking into their cycles, and then planning the protocols from beginning. And the doses, because if we give them the good dose, then suddenly the larger eggs, because they are big guys, they have more receptor FSH, they consume all the FSH, they become too big, and the smaller guys don't get any FSH, they don't grow. And then again, we could have this dyssynchrony. That's why then these regimes are very important. And then going backwards to 90 days before, then supplements, etc., to maybe wakening up more eggs, which we don't know. And this is now the main research is focused on how we can make those eggs come out so that we get more eggs.
Thank you. That was really, really useful. So are you saying then that for the supplements that were on the slides, they should be started 90 days before you actually start your first or subsequent IVF cycle?
To get the maximum benefit. It's a dose-related dependence benefit. You always get a benefit with them, but more the duration you give more opportunity for those growing eggs to have the raw material, right environment, etc., to grow. That's the first step. But in particular case, what you ask is why there are like only 2 to 3 eggs suitable for ICSI and rest other not. Then it's mainly to do with looking into the protocol, looking into how ovaries are behaving. Not everybody's ovary behave same way, and this is the main problem in the medicine overall, or the fertility medicine, is treating patient in the blocks. We again treat patient in high responder, poor responder, low responder, low responder, normal responder, high responder. So we tend to put them in the block, maybe block of 3, maybe block of 4 or 5, but every ovary reacts differently. And this is why this is very important to then get the optimal response by looking into their pattern. And sometimes first cycle we don't know, and not all the predictor model will give us accurate prediction, no matter how accurate we want to be. And again, second cycle could be a little bit different, but we could combine all these predictors together to have the right response. This is what I was talking on the personalized treatment.
Okay, thank you. Slightly off topic, I've got a patient asking, does endometriosis, can that affect IVF treatment?
Yeah, so how endometriosis, it's a very common question again. Endometriosis, severe degree, blocking tubes, physical damage can cause the problems, which is obvious and which everybody knows, or endometriosis in the ovary, and any surgery for that reduces the ovarian reserve. That's again known mechanism. But how the subtle endometriosis can affect the natural fertility is by creating the toxic environment inside, and then that can affect the quality of the eggs. There is good evidence that it can even reduces the fertilization rates. The wider evidence says that if it's a grade 1 or grade 2, it affects the natural fertility, but IVF, as we are bypassing some of the environment, we can bypass those effects. But still there is an effect on the quantity and quality of eggs and fertilization rate because of, again, as I said, all these pro-inflammatory markers there in the pelvis. So all these chemicals do damage.
Okay, thank you. I've got a patient that's got PCOS here, and they know they should eat a low GI diet to manage it. Should they do this right throughout their IVF to manage their PCOS? Would you recommend that they maintain a low GI diet?
Yeah, I mean, in terms of the diet and the PCOS management is a long-term management rather than having a very short-term fix. The PCOS has two effects. One is fertility and one is on general life and the long-term implications, and that could be managed with diet, lifestyle, etc. Now, particularly having any particular diet, as I said earlier, that is not necessarily the solution. It's also important to have the right protocol in PCOS because we might suddenly get the hyper response, and we obviously absolutely want to avoid that risk. We also have the problems on the lining, because if there is hyper response, that can desynchronize the lining and the implantation window could be missed. And then again, we won't get the success. So having those approaches are in the proper IVF cycle. This is the important bits. The pre-treatment optimization, as long as weight is controlled, the hyperandrogenemia, I mean, when weight is controlled, that can come under control. The metformin role is being researched, whether that helps to improve the implantation in certain cases. Inofolic or the other type of myoinositol type of supplements are tried in that line, but again, we haven't seen the conclusive evidence on that. But I mean, I don't think that one particular type of diet will absolutely cure everything. It's the combination of everything we need to look at. But I would be much more careful in designing the IVF protocol in the PCOS. The problem with PCOS is suddenly you don't get response. We increase the dose and the massive number of eggs come out. And then we need to control for the hyperstimulation syndrome.
Okay, thanks for that. I've got a patient here that's had one fresh IVF cycle, and from that fresh round, they then had two frozen cycles. Of those three embryo transfers, they've had two positive tests and miscarriages at approximately the 8-week stage. They still have 3 frozen eggs from that initial cycle. However, they're at a lower quality than the ones that have previously been used, but still have a level that they were frozen. And what the patient wants to know, are they likely to have a miscarriage again, bearing in mind they've already had 2 and the current embryos are of a lower quality than the ones previously used?
Okay, so this question is mainly related to the recurrent miscarriage as well as the success of the fertility. So recurrent miscarriage again is itself is a big topic, and I've done the research on and published paper on evidence-based management of miscarriage. But when we look into the miscarriage rate, we talked about the quality of the eggs and the quality of the embryos, and mainly when we say quality is the aneuploidy or the genetic copies of chromosomes, number of chromosomes affecting the quality. The fact the embryos are frozen tells me that they were up to a quality of becoming suitable for freezing. So that means, that tells me that the quality, morphological quality of the embryo is good. We don't do PGS, and it's not recommended to test every embryo for genetical normality or abnormality. And that's a different debate, but that tells me that the quality is there. What we don't know and what worth investigating is the other factors. That includes the blood clotting disorder, diabetes, endocrine disorders, the lining, the issues with endometritis, etc. And I think this is the full workup we should aim to do in the recurrent implantation failure or recurrent miscarriages. There is a good Royal College guideline on miscarriages, but British Fertility Society, which covers the whole of the UK for the British fertility professional, the BFS is about to publish a guideline. I'm one of the author of the guideline on the recurrent implantation failure. So the guideline is accepted, and that will be in the public domain soon on the BFS website, British Fertility Society's website, on the investigations and treatment of recurrent implantation failure, because that's the full topic in terms of discussing the systematic and the other causes. But I think it's worth looking into those before we go ahead with any subsequent embryo transfer.
Okay, yeah, and that's really good advice, and that's something you might want to consider having that conversation with your consultant at your clinic. I've got a patient here asking if two embryos are transferred, does that increase the live birth rate?
A good question, and it's a very, again, common question, one or two. Normally, we always campaign, and I work in the NHS and the private sector, and both places have the same questions, and we always promote one at a time. And Birmingham is the big unit for the management of twin pregnancy, and we can do everything for the twin gestation, including fetal treatment, fetal surgeries, etc. And this is one thing that we all need to understand as patients and doctors, that twin pregnancies has certain risks, but yes, it's manageable and we could manage that should that happen, but that's not the primary aim. So therefore, the clinic and the discussion, and this is the participatory care comes in, that patient in control, but we all are making that judgment. So if it's a good quality embryo and giving a very high chances of success with having the single embryo transfer, it's better to have the single embryo transfer, because that gives the ultimate good success rate, and we call it one at a time. If we have the suboptimal quality of two embryos, then that gives the marginally increased chances of success, but we are also taking marginally increased chances or risk of having a twin pregnancy. And that's the discussion. So it depends on the number of previous cycle, age of the patient, the quality of the embryos, and knowing all these risks, and then we all are making the informed choice. And fourth, an important thing is any coexistent medical disease or disorder, because then that could get worse if it's twin pregnancy. So we need to make this clinical decision based on that. Now, if we transfer everybody two embryos, will that increase? No, it won't. I mean, if the embryo quality is not very good, so if we put good and bad quality embryo together, the bad quality embryo can release the distress signals that may not be good for the other embryos. So we normally don't put two different embryos inside, and therefore then embryologist offer, okay, it's a top one, or it's middle, or it's a little less quality, and then we put both in. Yeah, that's what was expected, isn't it? That was the question, that whether two or one.
Yeah, that's a really useful question to know, because that's another question that I'm asked a lot, and something that patients really want to push their clinics on. So thank you. Similarly, just frozen cycles have a higher and more chance of implantation than a fresh cycle.
Good question. We did what we call in the UK e-freeze trial, and the trial was supported by the government, and that was a multi-center trial, that the study involving all major UK units. And this was the whole idea of the question, whether we should do freeze all or freeze everybody's embryo and have the frozen cycle. And there is, again, a subtle difference, and that's why personalized care or the care is important in planning the cycle. So number one, if we are missing the window of implantation in the fresh cycle, then the frozen cycle is recommended, i.e. if there is a premature rise in the progesterone level, or we take like 20 days to grow the eggs, and then we are collecting, or maybe 16, 17 days to grow, and egg collection is happening on day 19, day 20, or day 21 of the stimulation, then clearly we are missing the window, and then I would advise to go with freeze-all approach. But we also need to be mindful that if we freeze all the embryos need to be of certain grade and quality to be suitable for freezing, because then they need to withstand the process of freezing and the process of then thawing back. So that's two additional steps for each embryo to go through, and therefore they need to be robust or that level to give us a good success rate. And that's again the other tricky bit. So if I'm going to get two embryos with may not grow to the blastocyst stage, and if we decide to freeze them, most likely then again I'm not going to get the success what is expected in the freeze-all strategy. Versus if it's a PCOS or polycystic ovary patient, then giving the freeze-all approach gives the safety and the success balance, because we have plenty of eggs or embryos to choose from, and we can grow them, but we are not doing fresh transfer. That means we are reducing the risk of having the hyperstimulation syndrome. So normally then 18, 20 eggs, if we collect, I would say that definitely the freeze-all should have been considered in those approaches. And the other number of eggs, then as I said, it depends on the duration of the treatment cycle stimulation, premature rise of progesterone, lining in the fresh cycle. And that's why sometimes fresh is better, sometimes frozen is better. Again, freezing all cycles won't give us maximum success rate in all patients.
Okay, thank you. Back to the supplements you were talking about in the presentation. I've got someone asking here, should they have a test to see if they're lacking in any of those supplements before taking them? And they're also asking if they're not lacking in those supplements, is there a risk to taking the supplements? So basically, you know, should they be tested first, or is it safe to take them regardless?
Yeah. So again, this is a common question. And when we say supplements, by default, we mean that we are not correcting deficiencies. So if somebody is vitamin D deficient, the prescription of vitamin D is a treatment. And actually, it's not the supplement. It's not we're giving something additional. That has to be there. So vitamin D deficiency should be treated. And this is what GP does. Then we all do. We give the prescription. So there are tests available for certain things like vitamin D, folic acid, vitamin B12, etc. And if patient is deficient or having the less than normal level, then definitely they need a treatment for general health benefit, not just IVF or fertility, for everything. So that should be treated, and there is no doubt on that. Now, when we come to coenzyme Q10, then there are no tests. There are certain things that there are not tests, or they are not accurate, or we don't know the normogram, what it should be in the normal patients. Therefore, there are no developed tests. In those situations, then having this additional supplement, and as I said, by definition, it's additional thing, or antioxidants, if we want to be very scientific for certain medications, then they are antioxidants, then that will help. Now, if we are having the dietary vitamin C, having oranges and juice and lemons and etc., then having vitamin C in the pill or tablet, I mean, having dietary or natural substance is far more greater benefit than having and the vitamin C pill. It's always advisable. But if it does not possible, then this supplements covers that bit. When we talk about DHEA supplementation, there are some programs in America, and what they do is they do the measurements and then they prescribe the supplements. But then that becomes too expensive to have the test, treatment, then the post-test, and how that personalized program. And we need to balance the cost, because then that treatment or then that pre-treatment optimization becomes much more expensive affair. Then the logic comes that if the treatment costs less, there is no significant harm. And there is evidence or the prediction model clinically, we think that would be relevant, then there is a role of discussing this and using these supplements. Same with the melatonin. It's talked a lot, but again, there's no evidence and of showing it's too, well, there is no evidence to measure and then have the treatment plan for that. And B, using it or not using it, it's anecdotal. So some of these areas in the supplements or the additional medications is not very well studied, but some of these supplements are very well studied. And this is what I mentioned on the top is vitamin D, folic acid, some other arginine, etc., or all other antioxidants.
Okay, and just to add on to that, should you continue with the supplements after the embryo transfer?
Okay, so after embryo transfer, what is required is the right environment for the embryo, and that all comes with a pre-treatment optimization. And then the second and significant part is during treatment, having the right level of steroidal hormones inside the body with the stimulation protocol, with the supplement, with the drugs, which we give, progesterone or the estrogen and progesterone in the frozen cycle. And then maintaining that is vital. Now, having additional vitamin C, vitamin D may or may not, I mean, that's not going to change hugely. Folic acid is absolutely recommended until first 3 months of pregnancy. But rest other, we do not think that there is any role of enhancing the implantation, because whatever is prepared and made is there, and the implantation happens in first few days, and then that continues in. To get the positive pregnancy test, we need 10 to 15 days. Okay. So we wouldn't see the significant benefit. Biologically, it's not going to harm. Certain things, and embryo is very resistant to any drugs in this time. So again, we don't see any teratogenic effects in this time as well. But from pregnancy point onwards, we always say that discuss with doctors that any other preparation you're taking. From embryo transplant, clearly again, DHEA, I wouldn't advise. I would stop it when we start the stimulation. Vitamin C, vitamin D, folic acid, etc. if you take, is not going to harm from the embryo transport point.
Okay, thank you. Could you, I've got a patient here asking, is there anything we could do at age 44 to improve the egg quality, or is it too late? Is there anything at all from what you've said in relation to supplements that would help someone at 44?
Sorry, I missed a bit, Sharon, in the question.
Okay, I've got a patient who's 44.
Okay, yeah.
And according to your slide that you had earlier, it showed, our egg quality decreases with age. Is there any chance at 44 you could improve your eggs before starting treatment?
Yes, so the data, I mean, at 44, what is also important to know the reserve. So background ovarian reserve. So if the ovarian reserve is less, the quantity is less, as well as the quality is less, these things may help, but it's always difficult to predict as the natural conception rate goes down and miscarriage rate or failed implantation rate goes up. As long as somebody gets period and there are no tubal blockage or the no sperm factor, I never say never, because then there is always a chance of having a natural conception in the patient, and we have seen the natural conception across the board at different age groups. So nothing is 100%. Positive is not 100%, so as the negative is not 100%. So if I can't give anybody a 100% chances of success, I will not give anybody 100% chances of failure either. If at 44 we go with IVF cycle using the own eggs, we need to be very mindful of the reduced chances of success to the treatment, because the cost factor comes in, the stress comes in, and the invasive treatment comes in. If at 44, if somebody is trying naturally with the supplements, etc., and knows the age-related decline in the fertility, is a different approach than going ahead with IVF treatment at 44 and thinking that the supplements will significantly improve the chances of success. I do not think so. We need to balance the age-related decline and the risks of the IVF cycle, or the chances of having the risk associated with the invasive treatment. So that's the discussion between you and the consultant in the clinic. But normally I also guide to the HFA website for the national data on the IVF success rate at this age using the own eggs. And then we discuss. But I mean, if we try the supplements, antioxidants, and improve the health generally, will that help to the natural conception? Maybe, we don't know, but we are not saying 100% it won't help.
Okay, thank you.
Okay.
Another question I've got here with a patient who there's no nail factor, morphology and DNA fragmentation. Is the embryologist able to see from the blastocyst whether it was the male factor that contributed to the poor fertilization rate, or can they see if it's the egg or a combination of both, or is science not as technologically advanced as that?
Okay, so answer to that is I think it was a more of the personal opinion or the way of communicating the findings to the patient when we say that it's isolated one gamete problem when we are talking about the embryo or the zygote or the blastocyst quality. It's a very natural tendency to start from going from the known factor to unknown factors, because we all hate unknowns. We all hate that there's something unknown and we can't explain that. So DNA defragmentation itself and the tests for DNA defragmentation and the implications in the IVF cycle itself is the big debate in the fertility world. Therefore, whether the DNA defragmentation contributed to the quality of the blastocyst or not, it is a possibility, but it may not be just the one factor. It may be the combination of other factors. So therefore, that's very, very difficult, and I would never pinpoint to one factor, because we know that doesn't mean that that's the only factor that have caused the quality issue in the in the blastocyst or embryo, which by default comes from both gametes, and which not just both gametes, it's also us, the laboratory, the environment, the embryologist who is putting egg and sperm together. So there are multiple factors affecting that. One of the paper I published on the factors affecting fertilization rate, and in that we elaborated on the egg-related factor, sperm-related factor, and the environmental or the laboratory factors. And all these three categories are very important because everything has subtle implications on the outcome. And therefore, it's very difficult to go on the DNA defragmentation and claiming that one. What was the second part of the question?
No, I think the patient was just interested to see if the embryologist is able to see, they know they've got male factor DNA fragmentation with the sperm, but they weren't sure if they were also having egg quality issues. But
yes. Yeah, that's true. That we don't know that if there are like combination, but we always want to find. And sometimes even if we have absolutely normal egg, absolutely normal sperm, absolutely normal embryo, still we don't get 100% success. Yeah. And that's the difficulty for all IVF specialists or scientists, embryologists. If we don't know something is 100%, we can't always compare that with the other factors. Yeah. Because even if everything is textbook standard, we don't get 100% success. So yeah. Therefore, is something we find its tendency to say that, okay, this is what we found. But even if theoretically, if everything is normal, still we don't get 100% embryos implanted. And that's the problem.
Okay. I've got a patient here who was on the implant contraception for 7 years, and they're wondering if that's had an impact on the get high egg quantity in a cycle, but very low egg quality. Could that be attributed to being on the implant for 7 years, or would that have happened anyway? Are they just not making good enough quality eggs?
Sorry, 7 year of implant. Implant.
Yeah. They did contraception implant for 7 years, and they're now concerned that that's...
Yeah, I mean, yeah, the implants stops the ovulation, basically. So the process of atresia, and as in one slide I mentioned that at birth there are millions of eggs, and when the reproductive life starts, they become into few hundred thousands. So even without ovulation, the body keep losing certain eggs or number of eggs, and that is with the atretic process or the cell death process. In the simple word, there is automatic program in the cells and every cell of the body, and then they die after certain intervals. And some of these cells includes egg cells, then thus the atretic process happens in the cells. So it could happen anyway. So if somebody is on the contraception, let it be implant, let it be pills, let it be anything in that duration, we stop the ovulation. So we just stop the last beat of the cycle. What we don't stop is and therefore, theoretically, if somebody starts the, say, pills or contraception at age 20 and comes off at 40, will we expect the good egg reserve because they haven't ovulated at all? Answer is no, because there is still declining process will happen. The age-related decline in the egg reserve will happen in the body anyway. So that's why this contraception doesn't negatively as well as positively impact the quantity of the eggs and the quality of the eggs. So therefore, I mean, in certain studies, we have seen the transient decline in the reserve, testing reserve, in certain with a very long-term use of with pills or any use of long-term contraception, but that effect of drop is first 2 to 3 months. And the reason I'm saying this is 3 months, because as I explained you earlier, that 3 months before these eggs were suppressed with the hormone not to come out. And that's why it takes 3 months for that washout period, and then they start come out. But after 3 months time, it doesn't show any impact.
I've got 2 questions that are quite similar here. I'm sorry I've run over, guys.
No.
There is loads of questions. I really would like to get through them. So I've had a patient that's just had a failed fresh cycle, and their clinic wants them to wait for 3 bleeds before starting another cycle to allow the body to recover. However, the patient's feeling that they're ready just now. And conversely, I have another patient asking what's the optimum time to start another fresh cycle. So after a fresh cycle, where you've got frozen, what would your recommendation be?
So
and if you've got a fresh cycle and you only got the embryos that were transferred, so you need another fresh cycle, what kind of wait time do you think is optimum to make sure the eggs are ready and of decent quality?
It's again very good and very common question, and this is why again I'm going back to physiology, and I'm sorry if I'm too technical in this presentation to go back in the biology, but this is just to make the understanding clear where we are coming from, or where this duration, where I'm coming from. So if we have a fresh cycle, that means by default I have stimulated, or I tried to stimulate all the pre-antral follicles. They are ready and responsive to the hormones to develop them, grow them, and let them come out. So we have given the massive dose of drugs to get them maximum eggs out, because that's the whole idea of having the IVF, having the all cumulative chances coming together in one cycle, and so that we get that cycle successful. So by default, then we run out of this good egg, the antral or the hormone responsive bigger follicles from the ovary, and we need some time to grow the other cohort, which is lined up from behind, to grow to a level of becoming more hormonally responsible to start another fresh cycle. And that's why normally we recommend 2 bleeds after a fresh cycle to start another fresh cycle, because that 60 days duration gives that the cohort of the follicles which are just lined up to come up and ready to be stimulated grows properly, so that we can start the stimulating them and we grow them. There is also an upcoming philosophy of stimulating that smaller eggs and having the double stimulation and having double egg collection, but that's just marginally increases the number of eggs. But this is why classically in the standard protocols we advise 2 bleeds after the first cycle. 2 bleeds, that first bleed is the first negative test following the IVF cycle, and the second 1 more bleed, and then we are ready to go ahead with another cycle. Now if we are planning a frozen cycle after a fresh cycle, that means we are not worried about ovaries, what happens in the ovary, and we are not worried about the number of eggs coming out. So what we are worried about is just the lining and giving the right stimulus to the lining. And that's why 1 bleed is enough, that bleeds get rid of all the lining developed from the fresh cycle. And then for the subsequent period, we are ready to start the frozen cycle. So then 1 fresh bleed for frozen after fresh, 1 bleed is enough. Now, if we are doing any cycle after frozen cycle, unsuccessful frozen cycle, as we have not touched the ovaries, we don't worry about them. We have developed the lining, we transfer the embryo didn't implant, and we have a bleed. That means that developed lining has gone out. So therefore, then we are ready to start either fresh or frozen, and doesn't matter. So that's why fresh cycle after fresh cycle, 2 bleeds, frozen cycle after fresh cycle, 1 bleed, frozen cycle, and then any cycle, fresh or frozen after that, there's no requirement. That's the only 1 bleed. That's the bleed for lining to go away. Yeah.
Yeah, thanks very much for that. This is a more personalised question from a patient. They only have 1 follicle that's shown in the scan in the right ovary and 0 follicles in the left ovary, and their AMH is at 0.3. They are only 37, and they also have endometriosis and cysts, 2 centimetre cysts in the left ovary and 1 centimetre in the right ovary. With that clinical evidence, would you recommend that patient, could they increase their AMH level? And I know that's a $1 million question. Could they still conceive with such a low AMH and only 1 follicle showing 1 ovary on the scan?
Okay, so what's the age of the patient you said?
37.
Yeah, so what is important in the model is age and AMH. Low AMH at young age gives the better outcome than the low AMH and increase age. And the reason for that is quality is equal to the age, mainly because as age goes up, the quality goes down, and the quantity is mainly denoted by the AMH. Due to the pathology, existing pathology, endometriosis or some other thing, then the AMH shows the low reserve. The quality of the single egg could be better, but AMH is so low that going ahead with IVF cycle, we may not get more than 1 to 2 eggs anyway coming out. So that means having more invasive treatment and aiming for a very poor chances of success. That means around 5 to 10, maybe 5%. The chances of live birth rate with that using the IVF cycle. And this becomes the discussion. I mean, again, given the information, I can't give the direct prediction for this particular patient, but if we are discussing the principles, if there is a low AMH at young age, has the better chances of having a good outcome than the low AMH at the older age. And again, if we know the known pathology, that gives the better chance. The one follicle could be in this cycle. As I said, the cohort of eggs keep coming. AMH in this situation is very, very less, and that's the main issue. It's 0.3 is very, very less AMH, and that's why it needs then the discussion whether it's worth doing IVF or worth just trying naturally or correcting any other pathologies around to give the optimum chance to have the natural conception. One more thing we all need to understand or discuss or debate is fertility world always said that AMH is the panacea. In terms of, and you know, when my PhD and my research was started with AMH, and I believe that as well. But subsequent studies shows that AMH does not predict the chances of natural conception, because you need one egg coming out at one time to have one baby. And AMH is a good predictor for stimulation and getting the number of eggs out as a reserve. But in the American trial, they have seen that AMH does not always correlate with the natural conception or success using with the natural conception. So there might be ladies out there whose AMH is low and they are conceiving naturally. We don't know, because we're not testing everybody's AMH. We just test in the fertility scenario. So in this particular case, I think I wouldn't advise the IVF, or if IVF is planned, then needs a very detailed, in-depth discussion on the risk benefits and maybe, as I said earlier, that when to stimulate is also important. We might do the antral follicle count in subsequent cycles. And if we have good antral follicle count, that could be the right time to stimulate. If at all we agree on the decision, and that's what my advice would be.
Okay, thank you. As time is pushing on, I've only got a few more questions. So
yeah, no problem.
Back to the supplements. In terms of coenzyme Q10, is there a level? Because this is one of the most expensive supplements that you can actually buy, and it comes in different strength qualities from 200, 400, 600. As a recommended amount, you as a consultant would say to patients,
It's again a good question, and I personally did not find any evidence on what should be the absolute recommended dose, because as I said, there are no standardized measurements before, so then that makes it difficult, and it makes also difficult to see, because the trial didn't show the dose related response. But the maximum study shows 600 milligram of CoQ10 is a recommended dose. And that's what it comes from as 600. It starts from 200, but it's absolutely right that there is no conclusive answer here. It could range from 200 to 600. So some of my patients, I say, go with 600 dose, and I do appreciate it. It's one of the most expensive supplement.
Okay, thank you. A patient here has had 3 failed cycles at IVF. They've never been pregnant. If you had that patient, what would you consider before attempting another cycle?
Yes, so first of all, I recommend to have the in-depth review of 3 cycles. Normally, I say that after 1 cycle, it gives a good understanding for the second cycle. After 2 failed cycle, again, clearly we should have the better understanding for the 3rd cycle. And when I mention the understanding, that means how the ovaries are responding, how eggs and the sperms are behaving, how they are getting fertilized, or whether there is a problem with implantation. So normally I dissect in the review these cycles into 3 different compartments: pre-treatment, that what we did in the pre-treatment, and up to this level of starting stimulation. Then the second compartment is from stimulation to the number of eggs collected. The third compartment is then or the second B compartment in the lab, what happens. And then the third compartment is the embryo implantation to the pregnancy rate. So sometimes if the 3 cycles failed as a result of implantation issue, we should be focusing on the implantation issue, more on the eggs, embryo, and sperm issues. if the cycle is a problem in the second A compartment, that's the stimulation, or second B compartment, and both are iatrogenic, that we as medics and embryologists and everybody working in the field are supporting that. Therefore, the reflection needs on that cycle. And then the compartment A is a preclinical workup that, okay, we had the right prediction model, etc., is important. So I think that these cycles need in-depth review. I wouldn't say that just doing cycle after cycle after cycle will increase the chances of success. If we give the same input, we will get the same output. We need to change the input, or subtly change different factors. Sometimes, obviously, it becomes matter of chance. Sometimes we are successful if we give the same input, and we could be successful with a chance. But as I said, every cycle gives us some input, and therefore I wouldn't say that 3 is the maximum number one should have, or there is any set number. But if all these 3 cycles are telling me that there is an issue with egg quality or quantity, or there are no eggs, or cycle cancellation, or poor overhead response, and we have tried everything in each cycle, still we are not getting there, and that needs then thinking that whether it's worth doing another cycle or not. And this is the discussion on whether we were discussing the donor gamete. I'm also a trustee of a Seed Trust, which promotes the egg, embryo, and sperm donation. And then we guide patients to the information on the donor gamete conception. But as I said, before we hit that line, we need to reflect that we are correcting everything, we are getting the same response. So that's the answer, really. I wouldn't say that 3 is enough or not enough. It needs the reflection that what happened in all these 3 cycles.
Okay, thank you. Just 2 more questions and then we'll have to call it a night. I've got a patient who's going for PGD and they've been told they'll have to have ICSI. Is there a reason why a PGD patient would have to have ICSI as opposed to IVF?
Sorry, PGT patient have to have?
A PGD patient has been told that they will have to have ICSI instead of IVF. Is there a reason?
Yes, there is a reason. And the reason for that is because of the egg and sperms, we have more control on the genetic material when we are doing ICSI. That means we are ensuring that one sperm is going in one egg. So that's one thing. The second thing is there is no contamination from the other sperm's genetic material around the eggs, because in the PGT cycle, we absolutely do not want any errors when we biopsy the embryo, and we don't want any contamination. And that's the reason we want to have the absolute control on the combination of the genetic material coming from the egg and sperms, and therefore we recommend the ICSI. We also need to recommend the freeze-all cycle because there is a turnover time of these tests and getting the reports back, and that's another reason why we do ICSI and the freeze-all approach.
Okay. A quick question here, and it's about the grading of embryos. I've got a patient that's had been through a cycle. They've got grade 3AB, 4AB, 3BB, and what they're asking is there a chance that they could get a pregnancy from those embryo gradings?
Embryo grading is again very, very subjective, because the grading is based on the morphology. It's as good as looking at somebody and saying, oh, you look healthy, or oh my God, you're not looking well, type of thing. Although there is a science, and this is the joke about, but there is a science behind it. Science is mainly to see the morphology, how the embryo look, whether there is a segmentation, what the cell size are. As expected, as we all know, we develop from 1 cell, become 2 to 4, etc. So if the cell division is equal and nice, we expect to have the even number of cells. We expect to have the good size of the cells, as equal size of cells, and not having many segmentations, etc. So this is how the grading is. The embryos are graded, and this is how there is a full science on the embryo grading on the early or the blastocyst. But any embryos, and this is how I put to patient, any embryos we feel is suitable for transfer clearly have a chance to develop into a pregnancy. And nobody absolutely know that whether nothing is 100%. When we transfer, we get the pregnancies from not so good quality embryos versus we do not get a pregnancy in absolutely top grade blastocyst. And that's something variable. Therefore, anything which is suitable for transfer which is not abnormal cells like 1p end stage or 3p end stage. That means having two sperms fertilizing eggs, etc., as abnormal embryo, clear abnormal embryo. Rest all other embryos that we deem, yes, the chances could vary, and depending on the center's experience and the embryologist grading pattern, they grade it, but that differs. But as I said, like it's not that having little less quality embryo doesn't mean that it won't implant at all.
Thank you. And one final question here. I've got a patient asking if they had been through a hyper overstimulation cycle, does that affect the egg quality?
Sorry, which stimulation cycle?
If they've been overstimulated.
Okay, so the overstimulated cycle, it's again a very, very good point, and that's what I was mentioning in one of my slides, is the drug dosing is important, right dosing is important. Overstimulation cycle and young age, we got plenty of eggs. Statistically still we get good quality eggs out, but if we are collecting too many immature eggs, because that could happen in the overstimulated cycle, if the timing is not right, then that can affect the quality. The most important thing that can affect the quality of the eggs in the overstimulated cycle is coasting. Coasting is a phenomenon used in the standard long protocol where they drop the dose, or then they say that, okay, don't take the drug for 2 to 3 days or whatever, depending on the duration. And the whole idea is the hormones in the body to settle down so that we don't get overstimulation syndrome. So it's great to be safe. And this is where my P4 model comes in. Prediction is very important in this patient, so that we are predicting that what is required in terms of the response. But and we need to prevent the hyperstimulation as well. And that's why the protocol is important. Then rather than coasting, we could go on the freeze-all cycle, collect the eggs and store, and that does not affect the quality. So answer to the question is hyperstimulated cycle, how it is managed can have the impact on the quality of the eggs. But sometimes it's done to achieve the safety, and we take this trade-off to damaging the quality. But then the weights should be looked after of not coasting, because coasting is something I personally don't like it. Maybe my colleagues might debate on that, but my logic is if we are giving the set amount of drugs and the nutrition to the ovaries, and suddenly we withdraw that, that's not going to help those cells, and then that will affect. And this is where we see the problem in the coasting. So yes and no. Basically, if the cycle is managed appropriately, it may not affect. But if there is a coasting, there is immature eggs collected, clearly that will affect the quality of the eggs.
Thanks very much, and I think we'll just draw it to a close. Firstly, everybody, thanks for attending. If you've got any supplementary questions that haven't been answered, just drop me an email and I'll try and get that information. My email address is sharon@fertilitynetworkscotland.org, and you can email me or you can give me a phone call. My telephone number is 07411 752 688. This webinar tonight's been recorded, so we'll be put up on Fertility Network UK's webinar page. So if you want to then just take your time and go through the slides again or listen to some of the answers to some of the questions, feel free to do that. Dr. Jeve mentioned about stress and the impact that can have. Remember, Fertility Network UK run our fertility yoga every Thursday by webinar. You can register for that on our UK website page or on Facebook. We put out regular calls for it. And finally, I would just like to thank one of our corporate partners that brought this webinar to us, Coast Science. We're a manufacturer and distributor of fertility enhancing supplements, including coenzyme Q10, DHEA, and you can go and have a look on their website and see what they've got. And I'd like to thank most of all Dr. Jeve for his time. You know, you're a consultant in our NHS and your time is hugely precious, and I really want to thank you. And for some of the people that have asked me, yes, our next webinars, we are looking to talk about male factor and if there's anything we can do in relation to sperm. So that'll probably be in January time. And so thanks everybody for your time. This has been hugely popular and something that people want to get a better understanding of. So thank you, and thank you again, Dr. Jeve.
Thank you everyone. Thank you. Thanks.
Okay, bye.
Bye.